Good afternoon, everybody, and thank you for joining us for another one of our MAG Specialist Educational Seminars. Today we are joined with the very lovely Professor Rodney Lane, who is a vascular surgeon. Vascular surgery is an incredibly interesting field of surgery. It's a very bloody work, but it's absolutely fascinating, and there are so many different areas of expertise within this specialty. Professor Lane is actually doing another seminar for us in a couple of weeks about diabetic foot, but today's seminar is in the very interesting and topical subject of thoracic outlet syndrome. May I ask that you please keep yourself on mute during his presentation so that noise from your home or workplace doesn't cause any interruption to the quality of the recording. At the end of his session, there will be a time for you to ask questions if you would like, and if you don't want to speak up, you can pop your questions into the chat and I will ask them for you. The recording and slides will be sent to you within about a day after the session, sometimes on the same day, but usually within a day. And of course, they're saved to our YouTube channel that you can view anytime by doing a search on YouTube for Medicolegal Assessments Group. Thank you again for joining us, and thank you so much for your time today, Professor Lane. Over to you.
Well, thank you, Michelle. Today, the presentation represents a fairly large clinical experience with thoracic outlet syndrome. It involves young people, and so very important in terms of medico-legal considerations and payout, for example. So what is it? Thoracic outlet syndrome is compression of nerves, arteries and veins in the shoulder, and it's the exit foramen. So just enlarging this picture, so the nerves are behind, the arteries in front of the nerves, and then the vein is in front. And above is the clavicle, which is obviously very, shall we say, dense. The rib is underneath, that's the first rib. And in between the artery and vein is the scalenus anterior muscle. So the triangle is therefore consisting of two bones and muscle. So the definition: obstruction of the neurovascular structures exiting from the shoulder to the arm. So the types are neurogenic, so most of them, by far the majority, are associated with nerve obstruction. Venogenic, the veins being obstructed in front. And arteriogenic, 2%, where the artery is obstructed behind the scalenus anterior. So I'll just enlarge this diagram, and importantly, the trunks of the nerves are seen and the roots of the nerves coming out of the spinal cord are illustrated. Most importantly, there is a large nerve going on front of the muscle, on the scalenus anterior muscle. That's called the phrenic nerve. If that is tied off or damaged or cut, then the diaphragm itself is paralyzed. So therefore, if you do it both sides, you have a lot of difficulty breathing. But on one side, it's a very significant problem. So the symptoms are clearly related to what's the majority problem. In the nerves, always pain, weakness of the muscles, pins and needles, muscle wasting in the long term. Venogenic, in other words, the vein, again in front, is obstructed, and swelling, pain, and a bluish discoloration or cyanosis. Arteriogenic, pain with effort. In other words, the obstruction causes a decrease in the amount of blood getting to the arm. And so therefore, with effort, in other words, exercise, then the muscles run out of oxygen, and so that becomes painful. And so therefore, in the longer term, it can create problems with secondary events such as increasing the pressures in the compartments and causing the death of muscles and the loss of the arm. Obviously, coldness and pallor go with it, and again, exercise is the most important consideration. Again, I'm just going over this again. The boundaries are the first rib, the collarbone, and the scalene muscles, as shown by the circle again, the vein in front, the muscles in between, the nerves, and arteries behind. Okay, so the risks, everything relates to reduction in the exit foramen. So trauma, muscle hypertrophy, an extra rib, another a congenital rib which occurs in approximately 1 in 200 cases, pregnancies, scalenus anterior syndrome. So the important part is the differential diagnosis. When you are presented with these sorts of patients, the most important consideration is what sort of person is presenting to you. The important part is abduction of the arm. In other words, putting the arm above the head and with and without exercise. So the people that are involved are those that have to do this. This was originally described in housewives before the automatic washing machines occurred, and so basically they had to hang the washing out. And so having to hang the washing with pegs required the housewives to put the hands and arms above the head and do this repetitively. In these days, what we see are the fast bowlers, the basketballers, tennis players, window cleaners. Amazingly, window cleaners are a real issue with being able to work. In other words, many people have had to change their sport or their activity related to this syndrome. The most important consideration that most of these people are young. So if they have any issues with the medico-legal problems, then the compensation is very considerable. And just to give you a couple of examples, I was involved with a bullet, fairly famous bullet, where someone was shot 5 times, and one of these bullets was embedded very close to the exit, and after some hours of, shall we say, interesting surgery, we were unable to create a foramen, and we had to artificially create enough room for the nerves, arteries, and veins to exit. We did take the bullet out, by the way. The other interesting thing is the last patient that actually we saw was a fast bowler from the women's side for the Australian team. They were a fairly important person, to say the least. And we were made aware by Cricket Australia and a number of other people how we should be very careful with this particular patient for lots of reasons. So the differential diagnosis is important. Rotator cuff. Rotator cuff is very common and occurs in an older group of patients, and usually the ultrasound and the investigations are pretty clear on making the diagnosis. The rotator cuff is the cuff of the muscle called the supraspinatus, and it's at the point of the tip of the shoulder, or just around that area. And the big difference is the so-called frozen arc syndrome. In other words, when the arm is abducted between 60 and 120 degrees. This activates this muscle, which is either torn or completely severed, and they develop pain. So this is usually confirmed with MR, CT, and an ultrasound. So it still can be confusing in the first instance. A more important one is the pectoralis minor syndrome. Now, these are different group of people. These are young people again, but these are the gym junkies. These are the weightlifters. These are the so-called Arnold Schwarzenegger syndrome. So these are the guys that can do push-ups with one hand, and they hypertrophy this particular muscle in association with the pec major. And so it's if you make that diagnosis, a very small incision dividing the pec minor gives them complete and absolute relief in all of the cases that I've done. So basically, if you can make that diagnosis in the gym junkie, then not only are you popular, but it's a very, very good operation. Cervical root obstruction is much more complex, and we always need to get association with a neurologist who do some of the more sophisticated investigations, such as electromyograms, which we'll go into in just a moment. So if we have a look at the clinical examination, this is very, very important. And again, it's all related to position. The bailed up position is important, and you can imagine the housewife hanging out the clothes, how she's really doing the bailed up position or Ned Kelly position all the time. And to add to that, you use exercise such as giving them something to squeeze so that you increase the actual amount of effort required to increase muscle activity and therefore increase the flow and therefore cause the obstruction. This is an angiogram showing a patient with thoracic outlet syndrome. This particular type is the scalenus anterior syndrome, and you can see that the angiogram is done with the hands up position, and the obstruction on that side, that's on the left side, is complete. If you have a look on the other side, that also is affected. So the treatment depends upon where the obstruction is, but importantly, the investigations are very, very important to decide exactly where the obstruction is, because the operation changes according to what's required. So we've made the diagnosis. With the investigations, we've said we can do angiogram. The first type of procedure done is a duplex ultrasound, again with exercise, with a bailed up position and pressures measured using the duplex scanner, the Doppler, to make sure the symptoms are repetitive associated with the pressure changes. So what shall we do with these people? So the first thing is very specific physiotherapy. That's pretty easy with a woman these days who are hanging out the washing. You buy her a washing machine that dries the clothes. That's simple. But most importantly, that they change the type of exercise. If you're a fast bowler, then it's a little more difficult, but modifications of the actual type of delivery has been done very successfully. I won't go into detail, but this is very specific physiotherapy, and there are groups of physiotherapists who actually do this, particularly in Sydney. So if the physiotherapy has failed, and the symptoms are persistent, particularly if there is very objective evidence of obstruction, such as that angiogram that we showed, or the electromyogram shows very specific nerve slowing or conduction defects at a particular level, then we do the surgery. So the surgery that I've done, and it's fairly universal throughout the world, is transaxillary resection of the first rib. This allows the neurovascular bundle to drop down onto the second rib, and so therefore allows the obstruction to be corrected. So how do you do that? First of all, the incision is under the arm, so it's cosmetically very good. Remember, a lot of these patients are young women, so clearly you want to try and preserve the scars. Basically, two assistants and sometimes 3 assistants are required, as some of these guys in particular are very muscle bound, and so it does require help, to say the least. In any case, to try and get around this, it's now available with a robot. I have an experience in this. The real problem has been with the robots is that they still have difficulty getting the actual rib out. So the incisions that end up with the robot are they're more and smaller, but still there's an issue with robots. The group of people that are often associated with this is the thoracic surgeons. Scalenus anterior resection is an important one. That angiogram I showed you showed an obstruction of the scalenus anterior. That's the muscle in between the vein in front and the artery behind. And this is approached from the neck, and the anterior scalenus anterior is divided. The issue here is that surrounding this muscle, as I showed you in the first slide, is the phrenic nerve. And the phrenic nerve is easy to injure, and it doesn't recover. So if it's cut and even joined again, it does not recover. So it's very important that the surgeon doesn't injure that. The other factor is the thoracic duct. I haven't brought this up before, but on the left side, there is a very large drainage tube coming from the abdomen, going all the way up the spine and entering the vein on the left side in the front of the scalenus anterior. This thoracic duct carries all the lymph from the lower part of the body. So if you put a hole in that, then it's a nightmare, because the lymph tends to leak and to form a large collection of fluid, of lymph, and may in fact come through to the skin and cause a so-called lymphatic fistula, a nightmare. The other operation that we do is removal of the first rib, the cervical rib, which is the extra rib, as I mentioned, occurring in a couple of hundred patients, and that's a fairly simple procedure, and the results of this operation are excellent. So from the complication point of view, and I've done this once in a very large person, removed the second rib rather than the first rib, but fortunately we did obtain an X-ray and found that we need to have a first rib removed. Sometimes hemopneumothorax, in other words, getting blood or fluid or air in the pleural cavity. So the drainage is essential in the treatment of these cases. Phrenic nerve, I've mentioned. Thoracic duct, I've mentioned, and continued pain is the issue. The main problem is that even though there may be a vascular problem or a venous problem, sometimes there is continued pain, and even though we resect the first rib and decompress it, the patient may have dissatisfaction associated with continued problems. Again, from the medicolegal aspect, the phrenic nerve, the T1 nerve root is the root supplying the small muscles of the hand on the little finger type side, and this can take a long time to get better, but eventually it does. So, in summary, this is an uncommon problem, I guess, from the surgical point of view, because most of these people are adequately treated and essentially not cured, but able to cope with their profession by physical therapy. So thank you for listening to that. If I can help you with any questions, I'd be more than happy to do so.
Lovely. Professor Lane, thank you so much. That was neat and clean and good explanation. I certainly learned a lot more about that myself through that process. If you want, you can stop sharing, and that way the screen will write itself. Now, we have had a question from somebody during this presentation, and they asked, what would be the usual time for improvement to be seen if a person were being conservatively managed with physiotherapy for thoracic outlet syndrome?
Yeah, 3 months.
3 months. Okay.
Yeah, you can check your HCF or your MBF or whatever, because you're going to need 3 months of physiotherapy minimum.
Mm-hmm. Hang on a moment. I'm just going to. There we go. All right. Now, and I had another question from someone who's unable to attend today, and they asked, is thoracic outlet syndrome something that is easily misdiagnosed, and what things could it be? Could it either be diagnosed as, but it isn't, or could it be misdiagnosed as in the interim?
Yes, the short answer to your question is that it is misdiagnosed. And another segment, as I've tried to indicate, is that even though you do everything right and you correct what you think as a problem, some people still have symptoms. And I think part of this relates to the exit of the nerves from the spinal cord. So this is much more difficult. Therefore, we always get a neurologist involved, particularly if there are neurological symptoms. In many cases, these are mixed, but the neurologist is almost always involved. And so if we don't do well, we can say it's the neurologist's fault. So I think it's very important that you have some fallback procedure.
Lovely. Now, we've got one more question for you, Professor Lane. Someone's asking if you could speak to why this is such a contentious diagnosis.
Because the technology of diagnosis is not completely accurate, as I indicated, and they are often a mixed problem, even though the main problem may be vascular and you fix it, that there may be secondary neurological involvement as well. So it's not always straightforward in terms of the objective diagnosis bit falls a lot short of the subjective symptoms.
Lovely. Look, thank you so much, Professor Lane, for sharing your expertise and for explaining to us and giving us a greater understanding of thoracic outlet syndrome. Thank you, everybody, for joining us today and for your questions. As I said, the recording should go out to you hopefully later today, but certainly within a day. Please join us for any future seminars. Professor Lane, thank you so very much, and everyone have a great rest of the day.
Thank you.